Hello, everyone. Good morning, good afternoon, good night, depending who you are. My name is Ricard Ferrer. I am coming from Barcelona, Spain, and I am going to moderate this symposium sponsored by Estor. During the next 30 minutes, we are going to discuss about endotoxic shock from pathophysiology to target complementary therapies. You know that hemoperfusion is one of the adjunctive therapy that we consider in some patients with septic shock. And we are going to have a very interesting discussions with three experts from the intensive care background to the nephrology background. So it's going to be a multidisciplinary discussion. We are going to hear the presentations, and we are going to have a short question after each of the presentations. And then if we have 3-4 minutes at the end, we are going to have a debate between the three speakers. So I'm going to introduce the speakers after at the beginning of the presentation. So we are going to start with the first one, which I'm going to do it myself. And I'm going to discuss about gut dysbiosis and endotoxemia in sepsis at COVID-19, pathophysiology first. So please go with the video.
I thank Estor for inviting me, and also Esicm. We will talk about endotoxin shock and polymyxin B hemoperfusion and rational clinical approach. So, is the cytokine storm a relevant?
Hello, everyone. I am Ricard Ferrer, head of the ICU in Vall d'Hebron University Hospital in Barcelona, Spain, and I'm going to discuss about gut dysbiosis and endotoxemia in sepsis and COVID-19. Pathophysiology first. Those are my conflicts of interest. You will know that the endotoxin is the major component of the cell wall of the gram-negative bacteria, and the endotoxin have two important parts in the structure, the polysaccharide and the lipid A, which in fact is the toxic part responsible of endotoxic shock. The human gut contains 25 grams of endotoxin, and I want to remind you that 0.0 milligrams of endotoxin is enough to kill a human being. In fact, when we talk about endotoxemia, we are talking about gastrointestinal translocation and also about gram-negative infection, but many other conditions that goes with shock and risk of translocation that explain endotoxemia. But the most important and most interesting endotoxemia is those coming from this gram-negative infection. In fact, here you can see in these old photographs how the antibiotic-induced liberation of endotoxin in E. coli can produce severe endotoxemia, very elegantly shown in this slide. In fact, the auto-injection of endotoxin in this laboratory technician generate a very severe clinical picture of multi-organ failure with fever, increasing white cell blood count, alteration on coagulation, and the patient was close to die, and the patient improved after administering antibodies against anti-endotoxin. So endotoxin is one of the PAMs and DAMs, especially is one of the PAMs, so the pathogen-associated molecular pathway, and both PAMs and DAMs are recognized by toll-like receptors, PRRs, and are the responsible of signal transduction inside of the immune cell that is able to activate the nuclear factor kappa beta that regulate the transcription of cytokines. So endotoxin is in the top of this cascade and is able to generate this inflammatory response. So, but it's not only inflammation. We can see in patients with sepsis that endotoxin is able to activate cortisol, catecholamines, vasopressin, and glucagon, increasing oxygen consumption and oxygen delivery, but also this immune thrombosis induced by the activation of the coagulation because of activation of inflammation. On counterbalance, there is an anti-inflammatory response, which is also adaptive. But you know that patients with sepsis have a dysregulated whole response with excessive activation of coagulation with DIC, coagulopathy, thrombosis of the microcirculation, but also an increase of inflammation with the production of nitric oxide, vasodilatation, increase in the permeability of endothelial cells with production of edema, alteration in the microcirculation and in the macrocirculation with decrease in oxygen consumption, cell death, and multi-organ failure. On the other side, we have some patients, but because also this regulated host response to infection has immunodeficiencies. But in most of the cases, patients are cycling from immunoactivation and immunoparalysis, and we have to know in which phase is the patient. For that, it's very interesting to analyze the activity of endotoxin, because this can be done at bedside and has a very nice correlation with endotoxin concentration. So endotoxin activity is the way we use to measure as a surrogate the endotoxin concentration, knowing that levels above 0.6 represents a level of high concentration of endotoxin and can explain endotoxic shock. In fact, there is a nice correlation between endotoxin activity above 0.6 and the need of vasopressors, and also a nice correlation between high levels of endotoxin coming from this study from John Marshall, showing that higher levels of endotoxin of endotoxin activity in this case have a good correlation with mortality. So in patients with dysregulated host response, we have endotoxin acting as a pump recognized by the monocytes, macrophages, generating the inflammatory cascade, able to produce alterations in the microcirculation, vasodilatation, leading to organ failure. But also I want to stress that these inflammatory biomarkers can produce direct effect in each organ, leading to multi-organ failure. Let's move to COVID-19 now. The exposure to SARS-CoV-2 virus produces no infection or infection that can go from asymptomatic to mild, moderate, and severe. And the reason for that, and the reason for what some amount of patients could die, is in the immunity again. So some patients are able to develop neutralizing antibodies and an adaptive cellular response, and others are not able to do that because, again, this is related in response to the viral infections with hypercytokinemia, coagulopathy, and organ dysfunction. So in this classification of severity, you can see that critically ill patients have not only respiratory failure, can have septic shock and multi-organ dysfunction, and in some cases with endotoxemia, as you will see later. So this is the picture of the patient with a healthy immune response, able to control the virus, with neutralizing antibodies and removing from the circulation of virus and also infected cell. On the other side, we have patients with a dysregulated immune response, with bad control of the virus, high viral load, and an increase in inflammation, trying to control the infection, but in fact the patient is not able, is not adaptive, is not able to control the infection, and there is a vicious circle with increase of inflammation. Those patients have high level of cytokines, but it's not like a cytokine storm. In fact, it's a hypercytokinemia that cannot be considered at the same level of patients with cytokine release syndrome, but in some cases can go with endotoxemia, as I said. Here you have the different phenotypes described by Gattinoni, patients with the different type of acute respiratory failure, because some patients combine inflammation with activation of coagulation, and depending in which is predominating thrombosis or inflammation, we can see different picture. We want to go for those patients who have severe inflammation and also extrapulmonary manifestations of COVID, especially interesting gastrointestinal manifestation, because can lead to also to endotoxin translocation, but also patients with cardiac dysfunction with a shock that also can lead to gastrointestinal translocation of endotoxin. Here you can see different patients in the ICU and in the ward and outpatients, and you can see that the level of viremia, so viral load, is higher in patients with the ICU, and also inflammation is higher in patients in the ICU. So in COVID-19, we are going to find critical illness with high levels of viral load, but also high levels of inflammation, tissue damage, and risk of translocation coming from the gut. And another picture that we have also described is that those patients have lower level of neutralizing antibodies, and that's why those patients have also a high viral load and need ICU admission. But in fact, those patients who are at more risk are those patients who have risk of an acute and chronic endothelitis, because those patients with obesity, diabetes, chronic cardiovascular disease, hypertension, obesity are those patients who have certain degree of endothelitis, and this endothelitis is enhanced during COVID-19 infection, and also some patients that have specific genetic background that can lead to this severe form of COVID. We have described different phenotypes in patients with critical COVID. Using this machine learning approach, and it's an unsupervised technique, we describe several risk factors for elevated mortality, and shock is one of the reasons, especially cardiogenic shock because of myocardial dysfunction, is a specific risk factor for mortality. But look at the different phenotypes of patients with COVID-19 in the ICU. This is the mild phenotype. Patients have no shock, no myocardial dysfunction, but this phenotype will have an increased mortality compared with the mild phenotype. This is the moderate phenotype. Those patients, in fact, have shock. And the subgroup of patients, the phenotype of patients with higher mortality are those patients that develop shock and myocardial dysfunction, probably related with translocation of bacteria coming from the gut. Also, it's very interesting to note that those patients with COVID-19 have high risk of bacterial superinfection and also fungal superinfection, and really this is the reason for mortality in some patients. So because of advanced age, some comorbidities, as we discussed before, prolonged invasive mechanical ventilation, and in the immunosuppression induced by COVID, and for the immunomodulatory drugs we are giving to COVID, those patients have higher risk of hospital-acquired infection, but also a specific risk of BAP. In fact, this is well known because in influenza, we have bacterial superinfection in a percentage of patients going from 16 to 23% in different years of pandemic during the influenza season. But however, in influenza, gram-positive cocci are the most important microorganisms. If we look to COVID, only 3.5% of the patients have bacterial co-infection at the hospital ICU admission, but 15% of the patients in this meta-analysis develop bacterial superinfection. So bacterial superinfection is quite common. And in fact, in the COVID trial that analyzed patients in the ICU, in fact, 50% of the patients develop bacterial superinfection, in this case, BAP. And this is double than the patients who develop BAP during influenza. And it's very interesting to see that gram-negative bacilli that can induce endotoxemia are number one in this type of bacterial superinfection. You can see here in this other study that in COVID patients, most of them develop BAP when the patients are in the ventilator for more than a month. And again, in this study, gram-negative bacilli are number one in terms of epidemiology. We analyzed that in our data set. We had included 250 patients from the first wave in our hospital, and we have seen that 150 of them develop BAP. And in fact, those immunomodulators that we use for COVID, like corticosteroids and tocilizumab, seems to have some relationship with this increased risk of BAP. And again, as in other studies, in our data set, we found that gram-negative bacilli, Pseudomonas and Klebsiella, are number one in the epidemiology of BAP in COVID patients. And in fact, BAP is an independent risk factor in the propensity matching of additional mortality because the infection itself, and also because probably the risk of endotoxemia. So I mentioned before that gastrointestinal involvement is very important in COVID patients. So in fact, 60% of the patients show gastrointestinal symptoms, and when we look to the patients admitted in the hospital, up to 81% of the patients have gastrointestinal involvement. And as I said, this is a risk factor for endotoxemia. In fact, these investigators analyzed the rate of endotoxemia in patients with COVID-19 infection admitted in the ICU and receiving mechanical ventilation, and 42% of them have endotoxin activity above 0.6. And the kinetics showed that this is maximum during the first 3 days in the ICU. It's important also to see that there is a synergistic effect of LPS and SARS-CoV-2 spike proteins in vivo and in vitro studies, showing that the maximum of inflammation is when you combine LPS with SARS-CoV-2 in these mice models of endotoxemia, showing that the endotoxin can magnify the effects of the viral load. We have analyzed that in our data set of patients with COVID-19 endotoxemia that were treated with polymyxin B hemoperfusion, and we find this nice relationship between endotoxin activity and SOFA score. So more endotoxin activity, more organ dysfunction, suggesting that maybe endotoxemia COVID-19 is a good target for blood purification with endotoxin absorption. So my conclusions are that COVID-19 critical ill patients have high viral load and inflammation, in fact, with limited treatment options. The treatment we are using for that, steroids and tocilizumab, that are nowadays the standard of care, can induce bacterial superinfection, and both of them and some of them can go with shock. Shock and bacterial superinfection can explain endotoxin translocation together with the gastrointestinal involvement in COVID-19. This explains that up to 40% of the patients with severe COVID develop endotoxemia. And of course, those patients, if they are in a severe condition, are a possible target for blood purification with endotoxin absorption. And with that, thank you for your attention, and I am happy to take questions in the debate. We don't have any. Go ahead.
So I will ask you something. So in your opinion, just to underline for the audience, which seems to be a good phenotype could have benefit from this adjunct therapy?
Well, we have to look...
COVID-19, obvious.
Yes, in COVID-19, of course, we are looking for endotoxic shock. I understand that not many ICUs have the possibility to determine endotoxin activity, so the potential phenotype are those patients going with shock. The cardiac involvement is relatively common, especially common also in young children that can develop multisystemic organ failure. So when this cardiac involvement and shock, we have the suspicion that maybe endotoxic shock is there and can be an adjunctive therapy for these patients that we are treating in the ICU. If the patient has a bacterial superinfection and again is going with shock, this is a second possible target.
Okay, thank you.
Okay, there are no questions coming from the audience, so please remind you can make questions, and we are going to have some minutes at the end for discussion. So it's my pleasure to introduce now Dr. Silvia da Rosa. She's a nephrointensivist from Vicenza. She's also next representative, very active in the society. So very welcome, Silvia. And please go with the presentation about endotoxic shock and polymyxin B hemoperfusion, a rational clinical approach.
I thank Estor for inviting me, and also Esicm. We will talk about endotoxin shock and polymyxin B hemoperfusion, a rational clinical approach. So, is the cytokine storm a relevant septic shock? Yes. Inflammation is a necessary evil. From one side, we have a pro-inflammatory response characterized by activation, leukocyte, complement, coagulation cascade. From the other side, we have anti-inflammatory response characterized by impairment of immune cell function and apoptosis of TB and the T cells, and we have an increase of regulatory T cells. So we have an insult, we have triggers, we have sensor. One of our triggers is represented by LPS, who is a bacterial cell wall component and is one of the most potent immune activators that gain prominence. And the interaction between endotoxin and toll-like receptor type 4 is able to evoke a really cytokine store. But liberation of LPS from bacterial cells is also after antibiotic-induced bacterial cell lysis, and these evoke a multitude of toxic biological reactions, causing deterioration in some circumstances. And antibiotic-induced liberation can so cause immediate adverse effects, promoting septic shock in patients. So we have immunocompromised host plus infection, probably inadequate antibiotic therapy, and we have high bacterial mass, high endotoxin release, and septic shock. And endotoxin release could be really high if we are using antibiotic as piperacillin. Other antibiotics can also cause intermediate, also low endotoxin release. So what we know that during episodes of severe endotoxemia, concentration of lipopolysaccharide and its lipid A subfraction are liberated from gram-negative bacteria and become elevated with the systemic circulation. And polymyxin B has profound binding avidity for the lipid A core subfraction of lipopolysaccharide. So the mechanism of binding avidity involves the development of attractive forces, but also hydrophobic interactions. So beyond peak concentration hypothesis, based on the modulation performed by using CRT, cutting the high level of anti-inflammatory cytokines, using high volume, high filtration, for example, like top membrane in CVVHD modality. Beyond this peak concentration hypothesis, we can have hemoperfusion with the action straight on endotoxin. In that way, we can limit organ dysfunction, we can avoid organ failure, and we can avoid death. In 1964, as we can see in this editorial published on JAMA, was just a therapeutic dilemma, the endotoxic shock, and they were not technique for removal or an activation of the causative agent, but we are in 2020 and now close to antibiotic therapy, sus control, we can perform extracorporeal endotoxin removal. And we can do that using adsorption, so using a cartridge with a resins or gel in extracorporeal circuit. And adsorption cartridge should be assessed in terms of device adsorption capability, represent the total quantity of a specific molecule that the device is able to absorb, and also selectivity, because selectivity is a safer parameter. So we have in commerce a lot of devices able to remove endotoxin, but also some are able to remove cytokines because they are the membrane with adsorption capacity and in a filter from dialysis. And it is important to understand how we can have the level of endotoxemia. So we can perform endotoxin activity assay, that is a chemiluminescent bioassay, based on the oxidative burst reaction of activated neutrophils to complement coated LPS, IgM immune complexes. And if we have a range from 0.6 to 0.9, we have endotoxin concentration of 1,000 to 4,000. And we have endotoxin burden, that is the amount of endotoxin in extracellular fluid volume equal to 12.5 and 50 microgram. So for level between 0.4 and 0.59, we don't know what is the real quantity of endotoxin, because it's not well established by the MEDICS trial. So according to the endotoxin dose response curve, an EA value of 0.9 corresponds to 4 nanogram per milliliter. So if We consider as a patient with the EA equal to 0.9 and a blood volume of 5 liters, the endotoxin burden in blood could be around 20 micrograms, but we have to consider interstitial space because there is a volume of 13,000 milliliters. So in that case, the endotoxin burden is around 52 micrograms. So when I told you before, we have to consider for the quality of the device that we are using, the device adsorption capacity. And if we consider the adsorption capacity of polymyxin B hemoperfusion, so thoramyxin, we have a really high, is equal to 64 micrograms, is really high if we compare that with the other device present in commerce as indicated in literature. So it's so high that we can fight better the endotoxin burden for value over 0.9. So in 1970, polymyxin B was discovered to be protective against endotoxin-induced hemodynamic shock, but at the same time was demonstrated that was extremely toxic for the kidney and the central nervous system, so was not used for this reason. Since 1994, polymyxin B has been bound and mobilized to polystyrene fibers. In that way, we can use for neutralize endotoxin in a safer way. In that way, using polymyxin B hemoperfusion, we can remove endotoxin, we can make a decrease of pro-anti-inflammatory cytokines, so we can do immunomodulation at the same time. We can recover from immunoparalysis sepsis because the device is able to decrease T lymphocytes. So in literature, we have a lot of study, a lot of randomized control trial from 2005 until today, and we have two data registries, UFAS2, phase 1 and phase 2. The first randomized control trial is a UFAS, was performed in Italy in 10 ICUs and enrolled 64 patients, and the absolute risk of death at 28 days improved significantly from 53% in the conventional therapy group to 32% in PMX HP-treated group. The trials was not blind, but the selected therapy was based on clinical evidence on intra-abdominal septic shock, and the EAA was not measured. Abdominix randomized control trial is a French randomized control open label trial, 240 patients, and mortality 20 days was PMX group 28% versus control 19.5, but was not significant. The trial had a lot of trouble because there were a lot of technical issues, a lot of cartridge coating and the failure rate, and the observed composite mortality was less than the estimate, including the sample size calculation, thus decreasing the power of the study to detect difference. Euphrates randomized control trial, United States and Canada, 50 ICU, multicenter blind sham randomized control trial, 450 patients with septic shock and confirmed endotoxemia using endotoxic activity assay greater than 0.6. No difference was found in 20-day or cause of mortality, as was interesting because patient with there were a lot of patients with endotoxic activity assay 0.9, so was extreme endotoxin burden. So an amendment of protocol was performed, and mods of 9 or less, patients with the mods of 9 or less were excluded. So Euphrates, we have a post-hoc analysis, and the primary endpoint was 28-day mortality post-randomization, and the patient were patient with septic shock and the toxic activity assay between 0.60 and 0.89, and the 20-day mortality was significant in a reduction in 20-day mortalities between two groups. So those trials had a lot of troubles because probably the prescribed dose was not the same, was not standardized the timing, was probably too late, 24 hours, 48 hours. And we have results really different between trials. But if we consider our study, we have significant survival benefit, and we have more than 300 peer-reviewed articles on PubMed. What I do in my clinical practice? So when we have a patient with high suspicion of endotoxic shock and with a patient with septic shock, close to empirical antibiotic therapy and assessment of SUS control, we perform endotoxin activity assay because we want to confirm if this septic shock is endotoxic shock. So patient had serum lactate over 2 millimole per liter, vasoactive inotropic score over 50, SOFA score over 10, positive procalcitonin, and in the same time could have endotoxin activity assay 0.6 sober or less than 0.6 but positive black culture. In that case, we confirm endotoxin shock, and we have a time frame of 6 hours. After that, we start with polymyxin B hemoperfusion if endotoxic shock is confirmed. And if patient has renal failure, multi-organ failure, but in particular, if the patient has renal failure, we start with the CRT as we have as protocol, institutional protocol indicate. And after 24 hours, we perform second treatment with the polymyxin B hemoperfusion. So what we do is a sequential extracorporeal therapy in sepsis because it's a new approach, is not validated in literature, but is able to provide the most suitable therapy moment by moment for our critical patients. It is based obvious on expert multidisciplinary team. So for COVID-19 patients, it is important to figure out if this kind of patient had cytokine storm. If we compare levels with other patients with bacterial sepsis and similar, the circularity level of cytokines were really lower. So probably may not characterized by cytokine storm, but we know that they are characterized by immunosuppression, and we know that they are really high risk of patient for super infections. So probably those kind of these patients need to assess if they have septic shock. They should be assessed also for endotoxin shock because these kind of patients had SARS-CoV-2 spike protein that binds bacterial lipopolysaccharide and boosts pro-inflammatory activity. So we have a direct infection of the gut mucosa. We have a decreased antibacterial defenses. We have an increased mucosal permeability, bacterial translocation, and also systemic leak of endotoxin. So in patients with suspected or confirmed gram-negative bacterial infection, we have to perform endotoxin activity. And the result should be between 0.6 and 0.9 to start polymyxin B hemoperfusion. And should be started in early phase, so there is a golden hour, and should be used for 2 subsequent days. And if we have cytokine release syndrome, we can perform a sequential therapy with the hemoperfusion treatment. So we need the trials able to measure the ability of extracorporeal blood purification to remove target molecules, including assessment of the kinetics. We need also registry. We need to register our clinical practice. And this is case series in COVID-19 patients from UFAS to registry. And 10 patients, little, but they had really good results concerning SOFA score, lactate, vasoactive inotropic score, and MRT pressure that decrease all sequentially. And we use this flowchart in our center from May 2020 until today, and I register in our UFAS2 registry each treatment. So we had in 1 year 32 treatment, and the patients were not only with abdominal septic shock, 44 percent of patients had the community-acquired pneumonia, and this Apache-2 score medium was 27.50, with sepsis score was 71.50, and those are main pathology and comorbidities. What we saw was a decrease of vasoactinotropy score, a decrease of lactates levels, a decrease on SOFA. We had ICU mortality of 31%, less more, hospital mortality of 38%. We have a decrease of endotoxic activity because we perform a trend of endotoxic activity assay in those patients who we treat. And if we consider endotoxic shock, we have a decrease also, endotoxic shock in COVID-19 patients, we have also the same results, a decrease of vasoactinotropy score, a decrease of lactates, a decrease on SOFA, endotoxic activity, and procalcitonin. So to conclude, in a comprehensive approach to endotoxin shock treatment, the evaluation of kidney functions, vasopressor requirement, and endotoxemia should be performed together to sus control antibiotic therapy. And the monitoring should be dynamic, and also the prescription, because we want to achieve the precision medicine. And not only a specific treatment could be provided for every single patient, but even a more specific treatment shall be provided for every moment that patient has a particular need during his or her ICU stay. So I really think that polymyxin B hemoperfusion is a safe, is a good treatment, should be managed with in a really specific time, not so late. Is an adjunctive therapy that should be provided with close to antibiotic therapy and close to sus control, and for patients who have a responsive endotoxic shock, and we can also see the clinical benefit. Thank you for listening me.
Dr. Rosa, for this very comprehensive presentation. Very interesting. We have time for a short question. My question is regarding the registry. You have a lot of experience with the AOFAS2 registry. What do you think that the registries can help to understand where is the benefit of polymyxin B hemoperfusion in the setting of severe infections?
Yes, because the registry can help us to figure out which is the clinical practice of each center. And so we can improve ourselves, our clinical practice. I every time check my mortality, the treatment. If we can use it to perform a really good pathway, and probably we have to figure out which is the really right golden hour for this kind of therapy, and to reach a really good, to personalize medicine and to figure out which is the right patient for the right time.
Yes, I agree with you. I think registries are helping a lot in understanding which patients can benefit more from these type of therapies. Thank you very much, and I hope you can join at the end for a debate if we have some minutes. So it's time to move to the next presentation. So I invite to the podium Dr. Giuseppe Castellano. He's a nephrologist from Milano, and he's going to discuss about sepsis AKI and role of dialysis membranes, new frontiers in immunology. Please go ahead, Giuseppe.
Mr. Chairman, ladies and gentlemen, thank you to inviting us to present our data. Today we will talk about acute kidney injury and the role of dialysis membrane in septic AKI as a new frontiers in immunology. The acute kidney disease that we know as an acute phase, and then there is a maladaptive repair that can induce organ death leading to dialysis, or we can have a full recovery in our patient. During this process, there is an adaptive repair or maladaptive repair that can lead to a different destiny. What we have learned in these years is that the complement system may have a pivotal role leading to tissue damage that can be induced by the classical, the lectin, and the alternative pathway, as you can see here in the bottom. And when complement is activated, then we can have fibrosis that is similar to what is induced, for example, by TGF-beta. And this fibrosis can also occur not only in the late stage, but in the early stage. The fibrosis we have demonstrated that is characterized by some cellular process, like the endothelial to mesenchymal transition that you can see here is induced by LPS, in which in this situation the endothelial cell differentiate in myofibroblast, as you can see here, by the double staining for CD31, that is an endothelial marker, and alpha-SMA, that is a myofibroblast marker. Another important process that is occurring in LPS-induced acute kidney injury is the pericite to mesenchymal transition, and this will lead to a progressive fibrosis that is induced really in the early stage of LPS damage. Another important cells that is influenced by during acute kidney injury are the tubular epithelial cells, and we know that complement is pivotal in inducing cellular activation, cellular senescence, and we have shown this in acute injury model in pigs. The cells that are activated during this process are senescent cells that can lead to inflammation and fibrosis into the cells, into the kidney. So the consequence, when we have complement activation in acute kidney injury, so we have tubular interstitial inflammation, chronic inflammation, and the development of these SASP cells that are the secretary-associated senescence phenotype. And these cells are characterized by the process of inflammation, in which the senescent cells have a reduced Klotho signaling. It is the most powerful anti-aging factor, the activation of the VNT beta-catenin, the upregulation of cell cycle inhibitors, and epigenetic changes. So we do not have a regular senescence, but we have an accelerated senescence. So what happened in sepsis? We know that in sepsis there is an evidence of infection and then a life-threatening organ dysfunction. And we have we know very well the PAMs and the DAMs. Between the PAMs, we have the LPS, and in the DAMs, we have factors that are released upon LPS activation, damaging the endothelial cells and leading to multi-organ failure. So in our therapeutic approach, we should be able to modulate not only the LPS, but also the DAMs. And when we have activation on the surface of endothelial cells, there is the activation of complement and the coagulation cascade with the microcirculatory damage, with the microvascular thrombosis and microcirculatory dysfunction. How can we modulate this? We know the LPS structure with the lipid A, and with the polymyxin-based medical device, we can remove the LPS. But then, very frequently, we need a CRRT approach, trying to support our patient, also with the approach to the immune dysregulation. And with the CRT, we try to do an immune modulation with cytokine removal that is quite specific. However, now we have the possibility to use different kinds of filters, like the polymethyl methacrylate membrane with the absorption capacity. You can see here that PMMA can absorb really a high level of protein compared to a polysulfone based membrane. You can see here the difference in this picture on the capacity to absorb. So what our aim in this situation is try to protect the kidney, because the kidney, the tubular cells, as I showed you, the endothelial cells, the pericytes, are upon the activation of LPS, of complement, and there will be a accelerated fibrosis. So in this study, in vivo study, we tried to explore new pathogenic mechanism in a swine model of LPS-induced AKI, and we wanted to investigate the efficacy of a PMMA-based continuous hemofiltration approach in modulating what? Systemic and tissue immune activation in a swine model of AKI induced by LPS. So we analyzed the immune system, not only at systemic level, but also at tissue level, especially the innate immune system, the complement system. So we used the domestic pigs weighing around 60 kilograms. We perform an LPS infusion, and after 3 hours, we start treatment with CVVH using or PMMA filter or polysulfone-based filter. Then after 7 hours, we stopped the treatment, and then we went to a sacrifice in 24 hours. As you can see here, functionally, we had a better urine output and a better mean arterial blood pressure when we use a filter with polymethyl methacrylate compared with the polysulfone filters. And the difference was statistically significant, both in the urinary output and all in mean arterial blood pressure, indicating that CVVH with PMMA induce a better renal function, an improvement in oligonuria, and improvement in hypotension. Then we analyze the tissue of these pigs, and what we found was first that we had a reduced leukocyte infiltrate in renal parenchyma in CVVH compared with the polysulfone CVVH. And then when we analyze fibrosis with Masson trichrome staining, you can see here that LPS induced a massive fibrosis at tubule interstitial level. Polysulfone was not able to modulate this acute fibrosis. On the contrary, polymethyl methacrylate induced a slightly decrease of tubule interstitial fibrosis, as you can appreciate here, and this quantification was statistically significant. Analyzing the deposition of the component of the immune system, you can see here that LPS induces a strong deposition of pentraxin 3 at the glomerular tubule interstitial level and the terminal complement pathway, the C5b29. Polysulfone CVVH was slightly capable to limit these deposits. The PMMA-based CVVH was capable to abolish the deposition of these factors of the innate immunity, pentraxin 3, that is an activator of the complement system, and C5b29, the terminal complement pathway, protecting the kidney. Then we analyze the serum and the capacity of complement to activate at circulating level the classical, the alternative, or the lectin pathway. As you can see here, LPS induces activation of the classical pathway, the alternative pathway, and not of the lectin pathway. And when we analyze the treated pigs at 24 hours, we could see that PMMA-based CVVH induced really a strong downregulation of the classical pathway, and the alternative pathway indicated that we could find not only tissue ampred complement activation, but also the inactivation of complement was present at circulating level. Then we asked whether there was also the capacity to modulate the LPS binding protein that is important, we know, for the signaling of LPS, and you can see here that the capacity of PMMA to adsorb LBP was significant at 24 hours. Finally, we made a comparison of the whole genome gene expression profile of swine circulating leukocyte by applying an innovative omic approach. As you can see here, the whole genome expression profile was activated by LPS at 24 hours compared to basal condition. When we compare the PMMA treated pigs with the LPS pig, you can see here again that we found a significantly statistically modulation of the activation of the peripheral cells, the leukocyte. And when we focus on a special gene that were modulated, you can see here that LPS induced granzyme B synthesis in leukocytes that was downregulated by PMMA, or complement factor B was upregulated at 24 hours in leukocytes and was downregulated by polymethyl methacrylate. This is quite interesting because we also found a modulation of the complement system at tissue level and a circulating level in serum, but also in the synthesis by circulating leukocytes. And we found also modulation of other factors like C4b binding proteins, SERPINB1, IL-12, etc. So really, PMMA was capable to modulate circulating leukocytes. And now it's quite interesting because the role of complement has been strongly implicated in COVID-19, where we know that there is a dysregulation of the response of the host to the SARS-CoV-2 infection. And we know that there are superinfection in COVID-19 and multi-organ failure. And several publications have pointed out the role of complement in the amplification of tissue damage with several organs, like the kidney. And complement has been really implicated in the endothelial damage, but also in the tubular epithelial cell at the renal level. We have this damage. So really the complement system is a target also in COVID-19. Now, the conclusion are follows that in this new model of LPS-induced acute kidney injury, we demonstrate that these pigs, when they are exposed to LPS, they are protected by a PMMA-based CVVH compared to a normal polysulfone-based PMMH. What we can see is that we have a better renal function, we have a reduced classical and other complement pathway activation, we have less renal damage, less deposition of pentraxin-3, C5b29 with reduced fibrosis. And this is also found at the level of peripheral PBMC, but also at serum level in these pigs. So really we can modulate the immune system in these pigs by using this new filter. And the good news for our patients is that this technology now, after the preclinical model, is available for human, in which we have the thoramyxin and then the hemophil with the PMMA membrane for continuous therapy. So we can apply in this patient the sequential therapy. First, we absorb LPS, and then we are capable to absorb the complement system and all the other toxins that have been released upon LPS activation. I would like to thank all my collaborators at the University of Bari and the University of Foggia, and Professor Vincenzo Cantaluppi and Professor Claudio Ronco, also Estor and the Italian Minister of Health for this support. And I would like to thank you for your kind attention.
Thank you very much, Dr. Castellano. Very interesting translational research. I think this is helping a lot to understanding AKI in sepsis or septic AKI and how this sequential hemoperfusion can help to patients. My question is related to, of course, this is not coming from your animal model, but in your clinical practice, which is the consequences of PMEMA in long-term kidney function? Do you have any information on that?
Not yet, because this new device is recently available in our humans. What we can have is our experience in our patient in hemodialysis, in which we have used for years polymethyl methacrylate membranes, and we have very good results. And also in normal hemodialysis, we can remove also modulate the complement system, modulating the cardiovascular of our patient, the cardiovascular system, because I think it is important to protect the endothelial cells. In your lecture, in the lecture by Silvia, it is important to know that the endothelial cells are activated in active setting and also in a chronic setting, and they can differentiate in myofibroblasts. So I think it is important also for the timing. If we are late, then there will be already an endothelial differentiation and a transition towards fibrosis by LPS, but also by complement. So I think that it is really important to protect the cardiovascular system and the kidney, because LPS and the toxin released by LPS, complement and other cytokines, they can induce this that we call inflammaging. So this is an accelerated aging of the cells. And I think that it's difficult to go back from this situation, because you know that when we have fibrosis, it's difficult to revert the situation. So the timings for me is pivotal.
So I invite Dr. Rosa also to join the discussion. Thank you. Yes, so we have seen that timing is very important. Also, patients are quite different and they are in the different immunological status. And also therapies are evolving and now are much more dynamics with this sequential approach you both are discussing. Do you think this is a field for randomized controlled trials really, with such a heterogeneity of patients, immunological response and therapies, or it's better to keep to better understanding which is the physiology and the mechanism of action of and the mechanism background and also observational data?
Yes, we have probably to better define that, and after probably to start to design a randomized control trial. We have also in clinical practice differences concerning the clinical application. So we have to better define this first. I don't know.
And maybe, Giuseppe, we have to go for more kidney outcomes, maybe, than for outcomes in mortality, for example.
Yes, I agree to go for kidney outcome. Absolutely.
Yeah.
The type of AKI that is induced, the reversibility of this acute kidney injury, I think that for us is a very important outcomes.
Okay. Thank you very much. I think we have a nice discussion. We discussed about the pathophysiology of endotoxic shock, also about the pathophysiology of severe COVID. We learned that we are able to modulate both severe COVID and endotoxic shock with PMX hemoperfusion, but also PMMA membranes can also modulate inflammation and improve renal and patient outcomes in this new strategy of sequential kidney support and also support of the inflammation in these patients with severe conditions that in fact keep with a high mortality, despite we are able to reduce the bacterial load or the viral load with the different therapies we have. So thank you very much to both of you, and thank you very much for the attendees and also to Estor for supporting this nice session.
Thank you, Ricard. Thank you, Silvia.